Good morning, everyone. Welcome to today's webinar. My name is Rachel Browner. I'm the program coordinator for OneOps. It's my pleasure to welcome you to today's session on Medicaid and military connected families, current trends, and potential pathways to the future. In case you're joining us for the first time, I'd like to give you a brief tour of our webinar platform so you can find your way around. Hopefully, you're currently able to view the slides that we're sharing on the screen. If you're unable to see them or if you have any other difficulties, please email us at contact@oneop.org for tech support, and I'll post that in the chat here shortly for everyone. As some of you have already started doing, you started typing in the chat, letting us know where you're joining us from. Please continue to do so. That helps make this platform a little bit more personable since we can't see you and you can't see us. And we always like to read where folks are joining us from. To embed the chat pod, though, if you are having any issues with accessing it, simply place your cursor over those shared slides. From there, you're going to see a toolbar pop up across the bottom of your screen. Just click on that chat bubble icon, and then when typing any questions or comments, please be sure to select the Everyone from the Response Options drop-down menu so that everyone's able to view your questions or comments in the chat. And note that the slides and resources are available for download on the event page for today's session. And for those of you that are interested in receiving continuing education, we're going to talk more about that at the end of the webinar. So please stay tuned at the end if you're interested in continuing education credits or just a general certificate of attendance. And finally, closed captioning is available for this webinar, and you can turn on the subtitles via that Zoom toolbar. Thank you for joining us as we continue our partnership with the Department of Defense and the U.S. Department of Agriculture to expand that readiness, knowledge, and networks of the professionals supporting our military service members and their families. The views expressed in this presentation do not necessarily reflect the official policy of the Defense Department, U.S. Department of Agriculture, U.S. government, or OneOp, and the mention of any entity or product is for informational purposes only. I'm excited for today's presentation and presenter. Our presenter today is Dr. Christopher Pline. He is not new to OneOp. He actually works closely with the OneOp team, provides lots of support and services, and has also been part of our OneOp Lifespan Caregiving team for several years now. Dr. Pline is an Eberly Family Professor for Outstanding Public Service at West Virginia University. His academic research on health and social policy has been published in such journals as Health Affairs, the Journal of Health and Human Services Administration, and the Journal of Healthcare for the Poor and Uninsured. His expertise on Medicaid and health policy has led to invited presentations at the state and national level, presentation to the West Virginia legislature, and interviews with state and national media. Without further ado, I'd like to go ahead and pass over the presenter reins to Dr. Christopher Pline.
Thank you so much, Rachel, and welcome everybody. It's wonderful to see folks from all across the country and beyond. I noticed that we have colleagues joining us from Canada and from Poland and elsewhere, and it's wonderful that you all can be here today. I'm going to talk about a program, Medicaid, and I'm going to talk about a program that's really a central part of the architecture of healthcare in the United States. And in so doing, I want to talk about a program that is somewhat misunderstood, I would say underappreciated, and I would certainly say complicated. And so by the end of today's discussion, hopefully some of the mystery will be taken away from the program. We'll have a sense of understanding of its interface with military connected families. And we'll start to break apart some of the pieces of it to see where it might be going in the future. You know, our OneOp webinars are about professional development. They're about introducing our colleagues, our practitioners, our providers, our professionals to the important features of the landscape, the important environment in which folks engage and serve and assist service members and military family members with support and in promoting readiness. We know that today in our current times that programs like Medicaid are getting a lot of attention in the national media. We know that in terms of our military, that the Secretary of Defense has emphasized the importance of family support and family readiness as key to building and sustaining our military. And that a component of that is understanding and building partnerships with military and civilian resources. What we're going to see throughout is that Medicaid actually is a very important component that affects the lives of many on the civilian side and within the military. Those of you who are with us today understand, I think, so well that sometimes folks tend to place military existence outside of civilian world, when in actuality, there's a great deal of connection between both. And in fact, to promote military family readiness, we need to make those connections. We need to make those linkages. It's part of helping military connected families is to connect them with resources provided within the Department of Defense, but also without, if you will, in the communities, the states, and the national programs that exist to help them and to help us all. And so Medicaid is a really important program to talk about in that regard. It's interesting. Medicaid has been around for 60 years. It started in 1965, and it's a little younger than I am, I guess. But it started in 1965, and when it started, it was not anticipated that it would be a large program. It was anticipated that it would serve a number of folks who were very low income. But what has happened over time, over the 60-year period, is that we have found that Medicaid has become a key piece of the architecture of healthcare in our country. It provides coverage for low-income individuals and those with special care needs. Over time, it has expanded eligibility to new groups. And so where once Medicaid was reserved for really the poorest of the poor, increasingly, it's been expanded to lower income individuals and families, many who are working, many who are employed. It has become an absolutely essential component of elder care. It has become a game changer in the way that we perceive of long-term care, moving increasingly away from institutional-based care to community and home-based care. It has introduced us, some people may look at this with some chagrin, but it's also introduced us to managed care. Without Medicaid, managed care that as we know it, which shapes much of the private insurance sector as well as TRICARE and other government programs, we wouldn't know it as we do without Medicaid being a pioneer in managed care. Now, within the military context, it complements TRICARE in some military connected families. And obviously, we're going to talk quite a bit about that today. It serves as a key resource for those who are separating or retiring from military service and taking that step back into the civilian world, if you will. And so Medicaid, apart from being an item of some interest to us, Medicaid actually is crucial to us in understanding the role of supporting families for military readiness. So today, we're going to look at the relevance of Medicaid to military-connected families. We're going to explore in some detail, but not extensively, how Medicaid and TRICARE interact with healthcare coverage. We're going to talk a bit about what's called home and community-based services, because really, for a lot of folks, this is where they encounter Medicaid. It's in seeking to provide coverage and services for family members who may have special healthcare needs. for caregiving to our elderly relatives and loved ones. And so we're going to spend a bit of time on what we're going to call HCBS, because no webinar would be complete without a few acronyms or initials. And so we're going to be talking about HCBS. And finally, in terms of our learning objectives, we're going to talk about some of the major policy developments and proposals in Medicaid that are relevant to military connected families, but actually relevant to all of us. And so we'll go ahead and proceed on this journey today. It's a beautiful morning here in West Virginia, and I'm sure hopefully it's beautiful where you all are, and let's go on this journey together. And as some of you are attending this might know, this webinar is, I've presented this webinar in terms of an update over the years. And so we're going to give it a fresh perspective on the things that are happening today. So some basics on Medicaid. According to federal authorities, and according to the Kaiser Family Foundation, which we have all these resources at the end of the slides, by the way. Medicaid covers approximately 80 million people in the United States. That's about 1 out of 5 folks, okay? That's a big footprint, 80 million folks, all the way from newborns to moms, to working families, to the elderly. It's jointly funded by states and the federal government. And, you know, looking at the chat pod today and looking where folks are from, I see folks are from Georgia, they're from Virginia, California, Missouri, North Dakota, Texas, New York, across our country, okay? And forgive me for not including all the states there, okay? Each state has its own Medicaid program. It's funded by the federal government, and it's supported with federal dollars, but the programs are state administered. States also support and pay into the program, and they have wide discretion on how they operate these programs. So we have across the United States our 50 Medicaid systems in terms of all the different states, as well as the District of Columbia, right? And so one of the things that we realize is that unlike Medicare, the program that's primarily aimed at those who are elderly, you know, seniors, if you will, 65 and over, which is a very uniform program, Medicaid is a varied program. And this is a huge takeaway for us to keep in mind today as we think about working with military families and as they make decisions about where they may retire to, or the challenges or the opportunities they face in the PCS process. So with Medicaid basics, core benefits are required. And I'll talk about these in just a couple of moments, just to give you a few examples. But the big takeaway here is that Medicaid varies from state to state. And the match rates for what the states pay are different. So for example, in West Virginia, the basic share that the state pays for the Medicaid budget, the basic share is 25%. Okay, so for every dollar that West Virginia puts forward to its Medicaid program, it gets $3 from the federal government. I go across the border to the state of Virginia, and basically for every 47 cents that the state of Virginia gives towards its Medicaid program, it gets 53 cents, or we'll just call it 1-to-1 match, okay? So Medicaid formula funding is made up in a way in which states match to a certain degree based upon their economic capacity and based upon their need to a federal match. And so that's another thing to keep in mind, is that the funding for Medicaid also varies from state to state with different match rates. So we're talking money, so let's go to this. Money and politics often go together. Medicaid is oftentimes at the heart of political and budgetary debates. According to Oh, that's a great question, Jennifer. Jennifer, a great place to go to, if you all don't mind me taking a quick aside here, is a great place to go would be the Centers for Medicare and Medicaid Services, as well as the Kaiser Family Foundation. And again, at the end of the slides, there's a number of different links that you can click onto to get state healthcare facts. Okay, and so great question, and those resources are there at the end of the slide deck. So thanks for asking that, because it's really interesting to see what's happening in your individual states. But here's something, here's a big takeaway for today. The annual budget, when you combine state funding and federal funding for Medicaid, is $800 billion a year. About $600 billion comes from the federal government, and about $200 billion comes from state government. $800 billion a year. Now, that figure might ring a bell, because what large agency also has about an 800, or I should say department, has an $800 billion annual budget? And I asked that question rhetorically, but if anyone wants to add that into the chat, please let me know. Okay, I'll give away the answer. It's the Department of Defense. And so it's really interesting to think about that. So $800 billion a year. It's a lot of money. It's a lot of money at the federal level. It's a lot of money for the states. Even with the states that enjoy generous match rates, oftentimes Medicaid budgets put a real stress and strain on the fiscal conditions within the states. There's also a great deal of tension between federal oversight and state control. In fact, we're seeing some of this play out right now in the national political arena as conversations are going forward with the tax bill that's proceeding through Congress right now and has recently passed the House. States would like to utilize Medicaid in ways that they feel best serve their interest. And those interests can change over time based upon public opinion and need. Federal government oftentimes has wanted to be able to exert control over Medicaid programs, and at times encourage Medicaid programs to adopt new features. And so there's a tension, if you will, about control, oversight, and accountability that we sometimes will see between the states and the federal government. We also have to understand that because the states have so much discretion, we have 50 plus different Medicaid programs. And so that in and of itself is going to create some tension between the federal government and the states, because the way things are done in California might vary greatly, say, from the way things are done in Minnesota or in West Virginia or Vermont. It's frequently debated. Okay, so Medicaid is like, I pick up the headlines today, go online. I still get old-fashioned newspaper, delivered every morning, and you're going to see Medicaid in today's headlines because it's wrapped up in a lot of current politics. It's frequently debated as part of an entitlement or welfare programs. And it is indeed an entitlement program, which simply means that those who are eligible for income or other bases are entitled to this program. It's a social insurance program, not unlike Medicare, okay? It gets wrapped up in a lot of debate. And so we have to understand that sometimes there's a bit of fire and smoke associated with Medicaid. And in fact, right now, one of the big conversations is whether or not folks should be required to work to receive their Medicaid benefit. And so that's become a part of the landscape of debate. But let me give you this takeaway. Politics involved. It is so embedded in our healthcare system. It is so much part of who and what we are in terms of healthcare delivery in our country, is that it has profound influence and shape. Medicaid dollars don't go directly to individuals, to like the beneficiary. Medicaid dollars go to the providers and to the health systems. And those dollars and those funds, those programs, those priorities help to build the landscape of healthcare as we know it. And I was recounting a story about here in a rural state where I live, our hospitals are very much supported by Medicaid dollars, as are our rural health clinics. Schools with the specific programming for kids, things like that are all part of this. So So sorry about that little glitch, but that's where I wanted to set things there. Okay, so I want to advance the slide. I'm going to try to. There we go. So now we're going to focus on Medicaid and military life. And what I'd like to do is I'd like to talk primarily about, well, this slide in a way is sort of an overview slide. And I want to talk about such things as TRICARE and ECHO and how they relate to Medicaid. I want to talk about this concept called dual eligibility for both TRICARE and Medicaid. Also, I wanted to talk about how navigating systems can be complex for families, providers, and health systems. And that's the nature of what we have. We need to keep that in mind. Okay, so we know that over time that the military health system, Defense Health Agency, the TRICARE benefit has evolved. Many of you who are online today know that it's been evolving quite rapidly over the last 10 years or so, seeking to interface more with civilian healthcare systems, adopting managed care approaches, listening to families at times and advocates, benefiting from the input of state liaison officers and others to recognize the need to make the TRICARE benefit effective and more robust. One of the programs that has been developed over the last couple decades has been the Exceptional Extended Care Health Option, or the ECHO program, which provides an additional supplement to the TRICARE benefit, especially for families that may have individuals who have special healthcare needs. So the TRICARE benefit and the supplements such as ECHO have been developed, and they continue to evolve. The military health system, as we know, continues to evolve. It's an interesting history just as a sidebar, but we won't go there in terms of how it's evolved for the last 100 years. As it has evolved, it is also recognized that there's an interface with the civilian component. And that interface sometimes involves Medicaid. Many of you know that military families, active duty military families, may need to turn to Medicaid to supplement the TRICARE benefit. And this has often been associated with seeking specific services, such as home and community-based services. And but it's also at times been utilized to help military families who have lower incomes. And we know that Department of Defense has been working hard to try to raise pay and things like that. But there has been over time families that have utilized the Medicaid benefit to help with the premium cross-sharing with TRICARE and other aspects. But when we talk about the dual eligibility in TRICARE and Medicaid, we're oftentimes talking about families that have specific healthcare needs that TRICARE may not provide for fully, and Medicaid then becomes what is called wraparound coverage. Now, this is very well established and recognized, and the numbers are worth considering. For military-connected families, now that includes not just active duty, but it also includes those who are retirees and their dependents. The Medicaid and CHIP Payment Advisory Commission, which is a government entity called MACPAC, says that there's approximately 900,000, over the years, in recent years, there's been about 900,000 individuals who have had dual eligibility for TRICARE and Medicaid. And of these, about 220,000 have been children. Now, if we look just a look closer, MACPAC also reports that about 10% of all active duty military family kids in recent years have been duly eligible for Medicaid and TRICARE. So the military world obviously is closely connected to the system. And again, to emphasize, with TRICARE and Medicaid, TRICARE is the first payer, and Medicaid provides wraparound coverage, oftentimes coverage and benefits focusing on home and community-based services. So let's explore this just a little bit more. So again, as we've just said, some military families rely on both TRICARE and Medicaid, and it's not unusual. Coordination between the programs can be challenging, and I think many of you probably recognize that working with families. Again, remember this big takeaway. There's 50 plus Medicaid systems out there, and they need to work with TRICARE. And TRICARE in itself is a complex system. So you can see that these pieces working together can be challenging. Military families who might need home and community-based services, perhaps services to help a family member who has an intellectual or developmental disability, perhaps to help a family member who has autism, perhaps to help a family member who has a traumatic brain injury, a number of different conditions, specific needs. They may need to go outside of TRICARE for that service, and so they may turn to Medicaid for that. But because Medicaid is not uniform across the states in terms of the services that are provided, in terms of the way the services are provided, it can be difficult for families to access this. In addition, because military families move across state lines, it may be difficult to establish residency and eligibility for a specific state's Medicaid program. And I know many of you are familiar with this challenge, and it's a challenge of our federal intergovernmental system. Okay, it's kind of baked into the way we do things in the United States. And so one of the things that is happening, there's two big things that are happening, I would argue. One is that within the defense health infrastructure, there's been an increasing recognition that TRICARE needs to be a robust benefit. Programs like ECHO can help to fill in some of the gaps in services that have been identified. The Autism Care Demonstration Initiative is another example of trying to bring some of this, if you will, in-house with the military health system. On the other side, we're going to talk about this in a few minutes. On the other side, there are many at the state level in state capitals across the country who are seeking to provide ways to facilitate active duty military families and families relocating with separation into their Medicaid systems. And so there's a recognition of the challenge, and there are efforts underway to try to address these. So let's look at this a little bit more. Now, we were talking briefly about military family members who are in active duty status, but let's also talk about Medicaid and military transition. Think about the robust TRICARE benefit. Now, many will leave the military with TRICARE, some will not. Some will be able to go into a veterans health system, others may not. Medicaid, regardless, may be very important for continued support for families, especially if they need the specialized home and community-based services, that the in-home, the non-institutional based services that are oftentimes provided with folks with very specific healthcare needs. As I just mentioned, a number of states now offer active duty military family friendly residency eligibility policies. And you can go to Military OneSource and you can look under what the state liaison officers are doing. And again, that's at the end of the slides. We have a link there for you to see what's been happening in the different states. One thing to keep in mind, though, is that there's still a bit of work needs to be done to recognize the effectiveness of these policies, because most of them are fairly recent. They fall into two general categories. One category they fall into is that they seek to preserve the residency of families who are PCSing. So if a family's from Texas, for example, or a family's from Virginia, and the family moves to Alabama for PCS or what have you, their eligibility is preserved within, say, their home state, so that when they come back from their PCS, or when they retire, they come back to that state, they can maintain their eligibility. And this becomes really important because in some states, a lot of the HCPS services are provided optionally. under what are called waiver programs. And because these are special waiver programs, HCBS waiver programs, that provide in-home care and other services, it can be difficult to access and get these services, and the wait for getting these services can be quite long. So preserving one's eligibility in their home state, even if they move out of state, becomes very important. And the most common state response in trying to address the eligibility residency issue has been to do this. Other states have been accelerating the process in which individuals can gain residency in a state as they receive those individuals, that family, from another state. But again, we're still in the early stages of much of this. But there is, again, a growing recognition at the national level and at the state level, within the military and within the civilian world, of the importance of Medicaid to military life. So Medicaid can provide support for families after leaving active duty. It's especially important for those with special care needs and or lower incomes. And state by state differences in Medicaid may affect relocation and coverage decisions. If I needed to focus on, say, top 3 or 4 takeaways for today, please remember that state by state differences in Medicaid can be very profound. The Medicaid system in California is quite different than the Medicaid system in Texas. And again, the Medicaid system in Texas is quite different from the Medicaid system in Washington State, or in Virginia, or in Georgia, or Florida, or Colorado. And of course, I'm naming those states because those are states with very large active duty and retiree communities in the military. So let's take a look at this for a little bit more. Okay, so Medicaid becomes important after military service for many. They may be qualified for Medicaid because of lower income. Now, just to put this in perspective, because of policy changes that have been made over the last decade or so, Medicaid eligibility can be as high as 250%, 255% in some states of the federal poverty level for certain groups of individuals, mainly for kids and for expectant mothers, but also for those who are age 65 and over. And so that's a threshold that means that it's reaching families who are working, who are involved in hourly wage jobs, who are retired and living off of a fixed income, but not living in poverty. Okay, and so Medicaid is an entitlement program that serves individuals who have lower incomes, but are not necessarily impoverished. That's a very important takeaway. Another thing to keep in mind is that there are pathways to Medicaid eligibility that are not necessarily income dependent, but instead focus more upon specific health conditions or designation, for example, of receiving SSI or supplemental security income. In most states, SSI or supplemental security income is a gateway, if you will, to Medicaid eligibility. So families with special health care needs oftentimes do need to look at the SSI option and look at the eligibility procedures involved. The other important thing to think about is that because states differ, families thinking about relocation after separation from military service, and we know that military family readiness system involves helping people with that big jump, that big transition from the active duty status, that there really should be a lot of thought given to state policies, programs, and options in Medicaid because they vary so much. So another aspect that I think every one of us, whether we're connected to the military or not, face is the care of our loved ones. And many families will face long-term care decisions for aging and disabled loved ones. And Medicaid is a major key source of support for these needs. And thank you, Rachel, for putting that in there, that we have an upcoming webinar on SSI and also supplemental security disability income. But long-term care in the United States is greatly supported by Medicaid dollars. And this is something that folks may not realize. Oftentimes we think about Medicaid helping kids. We think about Medicaid helping working adults or low-income adults. But we don't always recognize the impact that Medicaid has on long-term care in our country, especially for the elderly, okay? And so if you think about this, the Medicare system, the Medicaid system, I should say, provides much of the support for nursing care in our country. It provides major payment for those services like home and community-based services like home nursing, special disease management activities and programs for folks outside of institutional care. This has been a huge game changer. I think most of us realize and recognize that long-term care in our country has moved from a model that's been institutional based to one that's more home and community based. So rather than institutional care, there can be personal care at home. There can be specific programs and activities at the community level that can assist folks in caregiving. And so with that in mind, Medicaid and military life caring for others is something to keep in mind. In fact, 1 in 4 Medicaid recipients is receiving long-term care services or supports. Long-term care is one of the major budget lines in Medicaid programs at the state level, and obviously in the aggregate at the federal level. Approximately 1 in 5 Medicare beneficiaries also receive dual coverage through Medicaid. A little bit more about Medicaid and home and community-based services. And again, this is our other big takeaway, that this has been a real game changer. These programs support those with long-term care and special health care needs. Remember, we're linking our takeaways together here. Each state has its own Medicaid program and it has a lot of discretion. The federal government requires all states to provide basic Medicaid benefits for all of its beneficiaries. And in terms of long-term care, this includes providing coverage for nursing home care if folks are economically and physically eligible. Because of that, Medicaid is a major payer for nursing home stays. In fact, about 63% of nursing home payment is from Medicaid. Okay. So states also are required to provide some home-based care as well, but it's a threshold. On top of home-based care, states can provide additional state-administered benefits for families in the home. Specialized care, home health nurses, special therapies, physical, occupational health, some equipment and such. And these are provided through what are called waiver programs. And as we've discussed, these waiver programs vary from state to state. Oftentimes the demand exceeds supply. So as a result, there are oftentimes waiting lists, which means that there's delay in getting some of these home and community-based services. And this delay can be for a family member, say a child who has special health care needs, but it also can be for a loved one who's elderly as well. And so again, the patchwork of programs that we have across the country allows for innovation and tailored services, but it also creates an uneven policy landscape, and families moving from state to state may encounter difficulties in accessing home and community-based services. And so again, something to keep in mind with our highly mobile military population. Okay, this is a little bit of a recap. Again, just emphasizing that states are increasingly addressing military family needs during PCS and separation. It's on the radar, everybody. And I think that what state liaison officers have been doing have helped put this on the radar. And as a result, many states have eased residency rules. Some are offering military preference and presumptive eligibility for services, though, as I said earlier, the more common tack that states are taking is to preserve eligibility and residence in a state, in a home state for a family that may be PCSing or progressing through their career.
Dr. Pine, we did have a question that came through. I don't know if you noticed it, but Terrell mentioned, is the benefit the same for those who receive their care through the VA and are 100% P&T?
I'm not quite certain what is meant by P&T, but the VA system is separate from Medicaid. But here's something really important to keep in mind. There is a sizable number of individuals, permanent. Okay, thank you. There is a considerable amount of interaction between the VA health system and Medicaid. And in fact, I have a statistic right here, which I'll try to share with you all. And I'll tell you what, if we can just hold off on that, I'll share it with you all as we start to wrap things up, okay? But it's a really important question, because here's the big thing. The Veterans Health System and Medicaid also interact with each other. So it's a great question. And there is some of those same tension points that we see between TRICARE and Medicaid in terms of getting two very large, complicated systems to work together. So let me kind of go into wrap-up mode here, and I'll address that question as we come across it in my notes, and we'll talk about improving Medicaid access and kind of take us home, because the hour is getting past us. So at the state level, there has certainly been work to try to ease active duty military family Medicaid access. At the congressional level, there has been interest, but there has not been federal legislation passed. But there has been congressional interest in this as recently as this year, and I can tell you from personal experience going back 10 years or so. State level policy changes reduce some access barriers. They still vary widely by state. It is recognized that DHA and TRICARE remains essential with Medicaid. Okay, so TRICARE and Medicaid, there's room for improvement. People recognize that. There's a lot of friction in the system because you have this unique health benefit called TRICARE, which is unlike other health insurance programs. And you have 50 Medicaid systems all working, and they need to coordinate in terms of who pays, who authorizes. And so there's some continuing challenges there. Medicaid is at the center of political discourse and politics right now. I want to let folks know about what's called Medicaid expansion. So I have 41 states have expanded Medicaid. There's actually 40 states plus the District of Columbia have expanded Medicaid, which has increased access for low-income adults up to 138% of the federal poverty level if they don't have kids. Okay, so Medicaid access is easier if you have dependents than if you do not. Okay, and so in 2010, with the Affordable Care Act, a provision was included that would allow states to expand Medicaid. 41 states have decided to do so, or I should say 40 states have decided to do so, as well as the District of Columbia. 10 states, primarily states in the South, but not exclusively, Wisconsin's also one of those states, have decided not to expand Medicaid. Medicaid expansion is at the focus of a lot of the current ongoing policy debate about funding changes and work requirements. It's gotten caught up in that current debate. Here's the big takeaway. About 20% of all folks who are covered by Medicaid today are covered because of Medicaid expansion, because of increasing I'm sorry, not increasing, but easing income restrictions to allow folks up to 138% of the federal poverty level to be eligible, including those without kids. Many of these folks are actually working. They have hourly wages, they have hourly work, but they're not provided a health benefit. And so Medicaid has kind of stepped into the breach and has helped to fill a gap. As we think about folks who are leaving military service, who may be single, who may be going into positions that are part-time as they find their way, or jobs that do not immediately offer health benefits, Medicaid can help to be a stopgap in providing health insurance. In fact, some states have actually recognized this with the military population for those who are separating and have sought to provide waivers and other ways of expediting their enrollment. So Medicaid expansion has increased dramatically the number of folks who are receiving the Medicaid benefit across the country. And again, it varies from state to state. In the state of Virginia, the increase has been profound, almost doubling the Medicaid population. In West Virginia, it's increased the Medicaid population, I think, on the order of about 50% or so. And so it varies from state to state, but Medicaid expansion is provision of the 2010 Affordable Care Act. States have the discretion to expand benefits. Most have. Some very large states like Texas and Florida and Georgia have not. But just so you know, that's part of the debate that's going on right now in Washington over the new tax bill as to whether or not those who are receiving health benefits under the expansion should be required to work. That's one of the narratives. We've talked about Medicaid spending. We've talked about the long-term services and supports. And again, if we think about the way we provide care for those who have special health care needs, for those who are elderly and have mobility issues, we recognize that increasingly that care is being provided in the home or at the community level rather than institutionally. That's been a big, big change. It continues to be the wave of the future. It drives major Medicaid spending, also creating economic and policy pressures. I'm just catching up on my notes right here. So the challenges that persist. And these are important things for us to keep in mind as professionals as we work with families and help others. Eligibility does not necessarily equate to coverage. Okay, so one may be eligible for Medicaid. One may be eligible within the TRICARE system. One might be eligible for ECHO. But it doesn't necessarily mean that they have secured coverage. Okay, so eligibility does not necessarily mean coverage. Folks may be eligible for something and they do not recognize it, and so they don't apply. Folks may be eligible for a program, but they're not able to get coverage because there's a wait list, as we've seen some of these home and community-based services programs at the state level with Medicaid. Coverage does not necessarily mean access. And I think almost everybody who's tuned in today can probably relate to that. for you've tried to make an appointment to see a specialist or to see a healthcare provider, and you have to wait, a week, 2 weeks, a month to see that provider. Or you live in a rural community and it's difficult to drive to the place where that service is provided. Or there's logistics, life gets in the way of caregiving, school, work, you name it. So coverage does not necessarily equal access. These are two very important things for us to keep in mind, because oftentimes we talk about eligibility and we talk about coverage and assuming that people are able to access and receive those benefits immediately or without friction and with ease. You all know, as professionals who help others, that there can be many barriers. And these barriers, part of what we do is, and part of what you do, I should say, is to help to break through those barriers and help families think about how to break through those barriers. There is state variation. We've talked about that quite a bit. In some states, there could be high transaction costs to receive and maintain eligibility and access to services. Okay. I think all of us can recognize that application processes, eligibility determinations, and redeterminations, they can be daunting. They can be complex. They can serve as barriers from people actually participating in a program. And so those who study social insurance programs and other programs often talk about the transaction costs that are involved in simply applying and maintaining eligibility and access for programs. And so one of the things that helping professionals can do is that they can help folks understand the benefit cost of applying for a program and the benefits that are received, and also to help to demystify the process. At the end of the day, trusted intermediaries matter. Those in the military family readiness system can help guide families through the system. They don't necessarily need to be subject matter experts, but they need to be subject matter familiar, if you will, with some of this landscape. And it's the programming like we're doing with OneOp, where we're hoping to help folks further develop the important talents that they have as trusted intermediaries. So what's ahead? Well, Medicaid is part of the landscape, and it often leads to adopting new care models. I mentioned earlier that managed care is one example of that. Key focus areas going ahead: long-term support services, home and community-based services, coverage for low-income adults, and managed care really are going to be the big issues that we debate in Medicaid. Right now, there's a lot of focus on the expansion population, but the real drivers of cost and the real drivers of demand are long-term support services, mainly in the home and in the community, sometimes at the institutional level. Key to all of this is ongoing expenses associated with Medicaid in particular. One thing that I want to stress is that over the years, Medicaid expenditures have increased, just like the cost of so many things. And so those cost pressures are a big issue. What's ahead? There's going to be an ongoing need to improve coordination with Medicaid and the Defense Health System. Again, this is not so much a criticism, it's just an acknowledgement that two complex systems working together we're going to have friction. Medicaid, for you as the helping professional, for you as a person helping to enable military family readiness and support, we know that during key transitions in the military family life cycle, that Medicaid may be particularly important to consider. Perhaps a family is facing special health care needs for a child. Perhaps the family is separating from service and will need to have Medicaid support for income or healthcare reasons. Perhaps the family is facing the challenge of caring for a loved one, an elderly loved one, who's facing decisions about long-term care, whether it should be in the home, whether it should be in assisted living or an institution like a nursing home. Some big takeaways. Location matters. Medicaid varies by state, impacting accesses and service. Medicaid is constantly evolving. It has shaped in so many ways our healthcare landscape, whether it's the use of managed care, whether it's the move away from institutional care for long-term needs, the focus on prenatal and early childhood care. Medicaid has all had a huge influence on this. And like anything that's important in our political landscape that costs money and involves choices and prioritization, Medicaid is politically debated, and ongoing discussions over funding, scope, and purpose are going to be there. This year, right now, there's a lot of visibility, a lot of heat, a lot of fire, a lot of smoke. But folks, I've been watching this program for close to 30 years, and I can tell you that Medicaid's always going to be at the forefront of attention. It may simmer, but then it heats back up. So we talked about some of the resources. I just want you to look at these. We have links to these. You can download the slides. I always try to put too much into one of these presentations, so please, my apologies. But this is such an important topic that for professionals, one of the great things to do is be able to look at some of these resources and references. And these resources and references are really aimed at the user. They're really aimed at the person who's helping someone navigate the process, as well as for those who are interested in policy. So take a look. Also, take a look at, excuse me, some of our recent resources of interest. And so to explore more on Medicaid, TRICARE, and special healthcare needs, we encourage you to take a look at some of our recent webinars that we've had, which are archived and accessible. And so take a look at these if you want to know more about the TRICARE Autism Care Demonstration Project or TRICARE Echo. These were recently provided. These were just recently presented, and we have some more older, but not that old, folks, I should say, webinars on Medicaid and on military family well-being. So if you're interested in this topic and what OneOp has to offer, take a look at these as well as some of our other programming. So Rachel, I'm going to turn to you, and I am going to also try to find this Veterans Affair question, okay? So,
All right, thank you. Thank you, Chris. I know we're at the top of the hour, so I'm going to have to go through these next few slides fairly quickly. But for those of you that are interested in receiving CE credit, we have several CE opportunities to receive one CE credit, or those of you that are just interested in receiving a certificate of attendance. I have posted those direct links. You will need to complete a survey first in order to receive your automatically generated email certificate. I've posted that link in the chat. I'm going to repost it again. That's a direct link to the CEs and certificates of attendance survey. Please know, though, that if you go to our event page where the PowerPoint slides are to download, where you were able to register for the event, if you scroll through that event page, there's going to be a nice continuing education section of that web page where you're going to see a purple button that says continue education. If you know of someone who's missed today's session, or if you want to go back and listen to the recording, we are going to post a recording to this. Give us about 1 to 2 business days to get that recording posted to the event page. But you're going to be able to still continue to receive CE credits and certificates of attendance for today's session. If you need to reach out to me, if you have any questions regarding your CEs or certificates of attendance, I am going to repost my email in the chat. Feel free to reach out to me. I'll try and help you the best I can as well with that. Also, please stay tuned for August 6th. We are going to be focusing on Social Security disability insurance and supplemental security income. We're going to talk about some eligibility criteria, that application process, and how SSDI and SSI interact with other benefit options. So this is going to pair very nicely with the with today's session. I saw, Carrie, you didn't have a place to add your info in the survey, please send me an email. I posted my email address. If you can, please send me an email and I will try and help you get that issue resolved. Stay tuned again, August 6th. I've posted the link to register for that as well in the chat. And then finally, we want to invite you all in August and September for the Academy, our Military Family Readiness Academy. It's an annual event bringing together military service providers from multiple disciplines to address important topics related to military family readiness system. And so this year, we're actually going to be focusing on challenges facing military youth and well-being. So over a course of 6 weeks, we're going to deliver a series of professional development opportunities where we have expert panel discussions, 3 webinars. So to find out more information about that academy, go ahead and get connected with us. You'll see the link in the PowerPoint slides on the screen. I also posted that to the chat as well. Stay tuned. Since we are a little after the top of the hour, we're going to be closing out fairly soon. So if
Right.
you can, go ahead and get connected with all those links in the chat or reach out to me directly. You'll be able to find all of this information, though, on the event website from today. Those PowerPoint slides, those CEs. If you have any questions for Dr. Pline or I, reach out to me. We'll try and get those resolved as well. And as always, connect with our OneOp team on a variety of different topics, whether it's lifespan caregiving, our personal finance, nutrition and wellness, our military child as well, family development. Connect oneop.org.
And Rachel, this is Chris, just jumping in real quick.
Go ahead, Dr. Pine.
Right. I had just wanted to give you all that figure for the Veterans Affairs. Okay. So according to the Medicaid and CHIP Payment Advisory Commission, 960 in recent years, about 960,000 Medicaid beneficiaries also receive Veteran Health Administration benefits. So about 1 million folks. So I just want to answer that question because it was hanging out there. Thank you.
All right. Thank you, everyone. At this time, we're going to go ahead and begin closing out. So thank you for attendance. Thank you, Dr. Pline, for your expertise, and hope you all have a